So thank you so much again. I'm going to focus this time on the assessment of the RV by Advanced Echo. Again, thanks to Dr. Datta and Dr. Ghosh. So the assessment of RV is important, and way back in the 1600, this is how a surgeon sees the heart once he opens up. You can see that Borelli, he was a student of Galileo, showed that the heart twists. The motion of the heart is on a twisting basis, and it is just like compared to wriggling of the water coming out of the wet cloth. And this is the anterior portion of the RV, which encircles and comes in front of the LV. So the heart is an important structure, and the RV assessment becomes very much imperative. The right ventricle anatomy is anteriorly placed. It wraps around the LV, and it is heavily trabeculated. The interesting part is the shape varies with loading condition, very much affected by the loading conditions because it drains into a low vascular resistance structure. Difficult to assess the volumes and function in two dimension, and we do need a three-dimensional perspective of the right ventricle. The RV is made just for the sake of transmitting blood to the lungs, not for nourishing them. This was an important statement which Dr. William Harvey said way back 400 years back. And we do understand that RV has an inlet septum, trabecular septum, infundibulous septum, and a volumic assessment of the RV is important and to understand how does it perform across a low vascular resistance structure. Now, the RV assessment is done by various factors. This is how the 2D RV looks. We have focus RV view. The RV is heavily trabeculated. It has a moderator band. The tricuspid valve is mostly apical as compared to the mitral valve, and the septal leaflet has multiple tendinous cords attaching directly to the ventricular septum from the tricuspid valve. And the RV superficial fibers are in circumferential orientation and deeper fibers are in longitudinal orientation. So we have two kind of fibers, circumferential fibers and the longitudinal fibers. And interestingly, the muscle fibers of RV and LV are in continuity. Why is it needed that we understand the how does the RV look? And these are more information from the advanced imaging, understanding that the RV and LV fibers are are continuously arranged. So it is no more no more a neglected entity. We have been looking at the RV extensively, an important prognostic value in ischemic heart disease, heart failure valves, a lot of conditions. As you can see, the survival goes down if you have RV function which goes lower. And the various ways the RV assessment can be done is by looking at the RV physiology. And the RV pumps the same amount of blood as LV, but using only 20-25% of the stroke volume. And RV pumps into a low vascular resistance structure with greater pulmonary arterial distensibility. So the various ways the RV measurement can be done is by M mode, 2D measurements, Dopplers, strain, and of course we have the 3D volumes. M mode is basically RV diameters, wall thickness. 2D by looking at the RV fractional shortening and RV ejection fraction, but we should not do it by 2D because we don't get a good representation. We have tie index strain analysis by Doppler and by strain 2D strain analysis. But what are the practical measurements and the clinicians which we can perform? So the most common, which came in the ASC chamber guidelines in 2015 by Roberto Lang, is looking at the TAPSE. It is nothing but the tricuspid annular peak systolic excursion, and anything less than 17 identifies an RV systolic dysfunction. And TAPSE does correlate fairly well with the RV function assessed by radionuclide angiography. You can also look at the diameters. There are different ways of looking at it, the base, mid, and the longitudinal levels, as also seen in the ACE and JACE ASC guidelines. Tissue Doppler imaging, looking at the RVS prime, is an important thing, can be done regularly. And the cutoff has changed from 10 to 9.5. Anything less than 9.5 is an indicator of RV dysfunction, a very useful entity in following up patient. But it has limitations. It is a one-dimensional assessment which is done, should not be used in patients who have TR involvement, severe TR, or if it has a surgery, cannot be picked up in patients who have arrhythmias, but is an important entity, and it can be an independent predictor of RV dysfunction in patients of heart failure. So we do now have RV strain assessment, which looks at the 2D spectral tracking, and this is an assessment of the strain, which where a global strain has been done involving the septum. We can do it, but now the guidelines have said that you always look at the lateral wall, the base, mid, and apical levels, and try to get a value. The point is, we do have dedicated now softwares available. The new machines do have RV strain, which can be done online and offline, looking at the strain analysis only. But if you don't have the new machine, you can still use the LV strain pattern on the right side and just take the values of these three and an average. So this is how does it look. It's a very important entity, and anything less than -20 towards positive indicates RV dysfunction on the lateral wall. The reason this septum is not being taken nowadays is because the septum is now being thought as is a part of the left ventricle. But we do it routinely, and remember the frames have to be maybe something around 40 to 60 to get a good strain values. So we are looking at the longitudinal parameters, and it does predict future involvement, future right-sided heart failure, and mortality in patients of pulmonary arterial hypertension. And RV free walls global longitudinal strain normally is cutoff is -20. Anything less than -20 is a marker of involvement of RV dysfunction, and it correlates pretty well with invasive hemodynamics in patients who have pulmonary hypertension. RV strain in valvular heart disease is also being used, and it has been shown that it can identify subclinical RV dysfunction. And BMV does cause an improvement in the both LV and lobar strain towards 3 months, immediate and post 3 months. This we have had reported in our work in JACE. So RV strain has a lot of importance in patients both of valvular heart disease, heart failure, and patients also receiving cancer chemotherapy patients. And this is now being identified, being put up extensively. And the recent role has now also come up in looking at the RV assessment in patients who are in post-COVID entity, because involvement of the right side in patients who have lung involvement or myocardial involvement in COVID patients can also give insights how these patients are going to behave. And I think a recent report came up showed that if the patient has RV dysfunction during the time of admission in COVID patients, they are going to do poorer over a period of time. Now, the RV assessment doesn't stop here, and we should have actual 3D acquisition of the RV. And there are now beautiful, the recent machines give you pretty good RV volumes, RV ejection fraction and stroke volumes in patients which gives you a good representation of all the variables. And this is one of the dynamic reconstruction which we have got from one of the machines. This is what is the RV EF and stroke volume and diastolic and systolic dimensions. So this is the tricuspid valve and the pulmonary valve which has been quantified. So the recent machines give you pretty good information on the assessment of the RV, and you can look at the RV volumes by various machines, and this should be routinely done. We try to understand that we need a dedicated training and learning curve in looking at the RV measurements, both strain measurements and the Doppler and the 3D measurements in RV. And it does need a very good image quality and a good learning curve to understand and use it on a day-to-day regular basis. So to summarize, that RV assessment can be done regularly, and this is we should always start with a focused RV view. Look at the TAPSE. This patient is a normal patient. The TAPSE was 24, which was normal. You can go ahead and look at the RVS prime, uh, and focus the global launches strain. If you have a dedicated software, that's fine. Otherwise, you can look at the lateral segment values. Global strain of -20 and above is normal, and try to identify what exactly is happening. The second patient of severe TR, where the torrential TR, the TAPSE was around 18. You have more data, what's happening with the RV function. We did the strain was looking pretty okay, but the RV, as you can see, the global launch strain was, I mean, we have taken the septal, but it should not be taken. We should only take uh, at the isolated lateral segment. But every patient where there is an RV involvement should have this workup entity, and should always be localized. The third case, a patient of RV dysfunction in pulmonary arterial hypertension, the TAPSE was reduced. As you can see, there is hardly any longitudinal excursion of the tricuspid annulus. More work, more images. The strains were reduced. The strain was very much reduced, and we don't have to get only the lateral segment in there. You can see this was going down. So these patients are going to do very poor in follow up, and we have to explain to them that the prognosis is bad in this kind of group. So RV is an important structure, should not be neglected, and it, as said, that it is a conduit from the venous circulation into the pulmonary circulation, and the concept of RV as a propeller has now come up. We have learned that the left ventricle has good vortices because it has got longitudinal, radial, and circumferential fibers. But so the LV has asymmetric large anterior directed vortices, but right ventricle, interestingly, is functioning only as a conduit. And this has now been seen that the vortex allows for an easy intraventricular transit of blood. And these are very initial studies are looking at the vortices of the RV. As you can see, the vortices, this is coming from uh, the tricuspid valve and going to the pulmonary circulation. But as you can see, the vortices are very minimal in the RV. Understanding that it all depends upon the muscle orientation. RV having predominantly longitudinal fibers and very less circumferential fibers in the RV outflow tract. So this is looking at the transient RV inflow vortices, which are maybe a future area of research. So in conclusion, that geometry and structure of the RV and the activation contraction sequence is intimately entwined with area sequence of blood flow. Understanding the RV function and volume is important, but also challenging, taking into account its geometry. You should never comment upon the ejection fraction of RV by 2D. Try to incorporate 3D. But in RV function assessment, non-invasively can be done by three entities: TAPSE, RVS prime, and RV strain values, looking at only the lateral segment. And we do need new non-invasive indices to understand the RV chamber compliance, to understand the RV remodeling in various cardiological clinical conditions. Thank you so much.